We are holding the second statewide health summit, which is an event that where we bring together people from all over the state, various sectors. We have people here from the healthcare industry, the nonprofit industry. We have people here from the faith-based community, and just regular people who come together for a day where we focus on healthcare and how can we make our state a healthier state. Welcome to this session. It is called Choice and Access to Healthcare When It's for the Long Haul, a Right or a Privilege for All.
How many people in this room have ever been on any kind of antidepressant, taken a kid to a psychologist, been to marriage counseling, felt anxiety, had a trauma in their life? Can I see how many have done that? Okay. Now, how many of you have eaten food out of a dumpster? None. And this is what's happening with the mental health budget. It is good. The ability to get treatment has become inversely related to need. So let me explain that a little bit. 100% of the population can have their mental health improved, okay? 18% have something that's in the Diagnostic and Statistical Manual. 4% have a serious and persistent mental illness. Now, we can debate whether it's 4%, whether it's 5%, whether it's 6%. The dividing line may be unclear, but the extremities are very clear. If somebody's walking down the street screaming, the FBI planted a transmitter in their head, chances are that person is seriously mentally ill. So it's about 43 million people nationally have a something in the diagnostic manual, and 10, 11 million have something that's a serious and persistent mental illness. For Louisiana, 18% of the population would be about 640,000 Louisianans have something that's in the Diagnostic and Statistical Manual, but only 142,000 have a serious and persistent mental illness. So what I argue is that we have to take money, we have to increase community services. It is a no-brainer. Nobody is arguing against that. But when we increase the community services, we have to go to where the problem is rather than where it's not. And I would argue that the problem is with the seriously mentally ill, not the worried well. For instance, we've all been taught that the mentally ill are no more violent than others. And it is true. The 100% who need their mental health improved are no more violent than others. The 18% with a mental illness are no more violent than others. And in fact, the 4% with serious mental illness are no more violent than others. But the 4% with serious mental illness who go untreated are more violent than others. And to be politically correct, we hide behind, oh, the mentally ill are no more violent than others. Most of the studies that prove the mentally ill are no more violent than others are either of the 18% with any mental illness or the treated 4%. They are not of the untreated. And think how logical it is. Psychiatric units are locked. Heart units aren't. Psychiatric nurses wear panic buttons. Those in cancer units don't. We are training police to go out and deal with the mentally ill, not people who have psoriasis. So and I have a mentally ill family member, a seriously mentally ill family member. Now, historically, 100% of our budget went to the seriously mentally ill. It was hospital-based. And by definition, if you're in a hospital, chances are you're seriously mentally ill. But over time, we've both moved to community services, which we should, but those community services are refusing to treat the same people who are coming out of the hospitals. They're cherry picking. Further, what happened is that we've defined everything as being a mental illness. Now, children, for instance, have worthy social service needs. But we now say, well, half of all mental illness begins below age 14. Yes, it's true, but it's mild mental illness. It's ADHD, it's anxiety, it's mild learning. It's usually stuff they grow out of, not to say that there aren't children with serious needs. But bullying and cyberbullying were never mental illnesses. Now they're mental illnesses. Trauma, losing a family member, losing a job, losing your home, used to be part of life. Now it's a mental illness. PTSD during World War I and II required you to be shaking, have tremors, sweating, nausea, vomiting. Now if you have a flashback and a nightmare, you have PTSD. Now PTSD can be very serious, but it runs mild to severe. Poverty, bad grades, unhappy with your sexual identity, these all now call on mental health funds, and this is diverting money from the most seriously mentally ill. So we have to spend money on the community services, but it has to go to those who need help the most, not the least. Now, Louisiana went from 903 psychiatric beds to 616 in 2016, a loss of 287 beds, and by the way, 70 are occupied by forensic patients. Louisiana has 8,200 seriously mentally ill prisoners and 1,800 seriously mentally ill in all the hospitals combined. That means in Louisiana, you're 4.6 times more likely to be arrested for mental illness than you are to be treated for it. Even if you add in the 4,000, all the 4,000 who are in the nursing homes, you're still more likely to be incarcerated for mental illness in Louisiana than you are treated for it. And by the way, that's not unique to Louisiana. And there are some good stats about Louisiana. The hospitals aren't kicking people out as fast as other states do at the average length of stay, so they're stabilizing patients before they're keeping them out. Now, I am not in any way, shape, or form arguing for a return to institutional care. What I am saying is that institutional care, some people need it. The number of beds that any state would need, assuming the world's most perfect community services, is estimated to be around 50 beds per 100,000. Louisiana has 14, and I didn't look up where that stands, but actually it may be relatively good compared to other states. What's happening is, as hospitals close, incarceration goes up, the connection is clear. And again, it's because community services aren't picking up the slack. Suicide goes up as hospitals close. As a result of this, and this is all about building coalitions, I now find that in my work, the strongest advocates for treating the most seriously mentally ill is not the mental health industry. The mental health industry has moved on to poverty, cyberbullying, trauma, wellness is a really big one, things like that. But it is criminal justice. Police, sheriffs, corrections are paying the cost of the mental health system abandoning the most seriously ill. Chief Michael Biasotti, who was head of the New York State Chiefs of Police and later on the International Association of Chiefs of Police, wrote that today we have two mental health systems. One is run by the mental health industry, which is treating those well enough to recognize they need care, and all others are being offloaded to corrections, police, sheriffs. When they take people to a hospital, he wrote a heartbreaking article, and he's got a mentally ill daughter. So that's why he's so concerned about these issues. He goes, but I'm a police chief. If I try to take if my officer finds someone with mental illness who needs care and they try to take them to a local hospital, not an institutional hospital, that hospital has no beds because of not enough state capacity, so it trickles down. So he goes, so my officer's going to sit there for 4 or 5 hours waiting to get evaluated. They're going to get seen by a doctor who's under pressure not to release. Even if they take the person, they're going to be on the street the next day. It's a lot easier for him to take the person directly to the jail rather than it is to treatment. And so I would not, if you're looking for partners in this, I would look to police, sheriffs, criminal justice system, because they're the ones who've been good. Mentioned as part of the Olmstead decision, one of the things that we have to do is we have to provide evidence-based community treatments. True. But there are 2 other criteria. Not only should they be evidence-based, they should be treating the most seriously mentally ill, and they should be reducing a meaningful metric. Right now, you can set up a suicide hotline, get 10,000 calls, and so your suicide hotline is a success. It doesn't matter whether suicides went down or right. Your report says we got 10,000 calls. It's measuring the process. We have to measure the progress, not the process. Programs that reduce, thank you. Programs that reduce homelessness, arrest, incarceration, suicide, meaningful metrics in the most seriously mentally ill is where our budget should be going, and it's not. Now I'm going to turn briefly to the, and let me just, before going on, let me mention some of what those programs are. Making sure somebody can get medications is probably the single most important thing that you can do for the most seriously mentally ill. Yes, they have side effects. No, they don't work for everyone. And yes, you need the other ancillary services. But if you need one, it's making sure they can manage their medications. By the way, that is a service provided very well in nursing homes. So as we're looking to comply with the DOJ findings or the settlement goes through, we want to make sure that medication management, which means access to doctors when needed, directly observed medication, long-acting injections when needed, that these types of services are available to those who are getting discharged. Assisted outpatient treatment. I got to say, it's not controversial. It's controversial within the mental health industry. Assisted outpatient treatment says if you have a history of going off treatment that has resulted in you becoming homeless, arrested, incarcerated more than 2 times in the past X number of months, then the court can order you to accept treatment as living in the community. It is a less restrictive, less expensive form of commitment than inpatient commitment or incarceration, the only 2 alternatives. By the way, the order is not enforceable, but I went to mental health court this week, and I'm going to get weepy again talking about it, but it was really striking because you see mentally ill people walking into court in handcuffs, because mental health court treats them after they've been arrested. And they come up and they talk to the judge, and he was kind enough to let me sit in the witness box. It's one of the things he did. He didn't want people to have to yell and tell everyone who's in the room. So in his court, the people come up and they talk to him, and he's got his case manager there, and they arrange treatment. And if the person can stay in treatment for 6 months and they come back every week and the judge checks on them, their charges are dropped. Well, assisted outpatient, that is basically what assisted outpatient treatment does, but it does it before the crime has been committed. So all these people are saying, well, let's train police better. Yes, the police need training, but we really have to train the mental health system not to ignore the seriously mentally ill. We have to make much wider use of assisted outpatient treatment for those who have that history of violence, arrest, or incarceration. I found out, I learned in the DOJ findings, I read the actual report, that Louisiana only has 14 ACT teams serving 1,100 people. Obviously, they need more. But what was more astounding to me about that was that means each team is treating 82 people. ACT is assertive community treatment that's supposed to have a low caseload. If those teams have 82 clients each, those are not ACT teams. That is not in intensive services. Nobody can manage 82 people. The DOJ is right that Louisiana needs more community services, but ask yourself the question. One of the wonderful and I would urge you to read the actual findings, not the summaries, but one of the things is they laid out a very good case for the fact that the Americans with Disabilities Act, as interpreted by the Olmstead decision, not only allows people to live in the most integrated setting appropriate to their needs given the state's resources, but that the ruling can be used to prevent institutionalization. Now that's an astounding use of it, is that we have a law or a Supreme Court decision interpreting a law that says we have a law on the books that we can use to prevent institutionalization, for instance, for the homeless, the psychotic, those people on the streets. So what's happened in other states, these Olmstead decisions are everywhere. It is part of this idea that all mentally ill can live in the community, and some people have to ask a question, well, yes, if my sister-in-law, who's the mentally ill person in my family, if she had 3 caretakers, so she could have 8 hours, 24 hours a day, she could live in the community. It's an expensive service, it's institutional. What do we have as an obligation to say? By the way, I'll argue we should pay for the round-the-clock caretakers. I'm an advocate for the seriously mentally ill. But is it the nursing home residents who do have a place to live who we want to be a priority population? And I ask that question because Governor Christie in New Jersey just signed his Olmstead consent, I don't know if it's formally signed, and he said he's going to increase housing, and I forget whether that was a hospital suit or a nursing home suit, but it was a hospital suit. So they were saying, well, these people in the hospital should be able to get out. Well, he satisfied it by taking housing that was allocated to other hospitals that weren't part of the suit, and now is going to allocate it to those hospitals that are. It was robbing Peter to pay Paul. So we have to prioritize services for the most seriously ill, and I would just be sure, and I don't have an opinion on this, that the nursing home residents are the ones who are most impacted. Is it the ones in the state hospitals, for instance, or is it the ones who are at risk of homelessness? Also, when you measure, if there is a settlement, when you measure this, they're going to measure this on how many people are out of nursing homes. So the population went from 4,000 to 2,000, it was a success. But jail may have went up. Deaths may have went up. The other thing is I argue for meaningful metrics, that we have to measure meaningful metrics. Understand you can achieve meaningful metrics, meaning reductions in homelessness, arrest, incarceration, and suicide, by serving the worried well. Take a less difficult patient and you're going to have less of those things happening to you. So it's very important to measure, and it's interesting that the auditor talked, because throughout the country it really is the auditors who are providing us a really good glimpse into what's going on the inside. So will Louisiana cut services for others? Housing. Housing's become so difficult that people don't even talk about it anymore. As part of diverting people from the mental health system, a commissioner of mental health told me, DJ, if I put a new social worker in the school, the PTA is going to throw a dinner for me and my picture's going to be in the paper. She said, if I open a new group home, my picture's going to be in the paper and they're going to run me out of town. So it is very difficult to focus on the most seriously ill, but it is not the kind of housing that the most seriously ill need. Isn't just scatter site apartment with drive-by case management services. Many of those people who have been given that are becoming as segregated, more segregated than those who are in the nursing homes. My own sister-in-law is a wonderful example of this. And by the way, I have data on the stuff I'm saying, so I'm not saying just because it affected my family. But she was in a wonderful group home, 8 people, and then they graduated her, that's a mental health system euphemism for kicking her out, to independent apartment. Well, she can't really read that well. She doesn't have the concentration. Medicaid sent her letters saying she has to be reevaluated. She never got reevaluated. She goes to the drugstore to fill her prescription, and they say you're not covered anymore. And the only way we found out about this is, the apartment started smelling from the food and the junk accumulating, and neighbors called us and said, we think there's something wrong there. So there is moving directly out of the nursing homes into independent housing on their own may not be the best course. Going through some sort of progression may be better, and I would urge you to watch for that if this goes forward. Anyway, so I don't, that's just kind of my observations about the system here. Alma is running this really great program on the long-term care needs of people, and asked me if I would come down and talk about the long-term care needs of the seriously mentally ill. The people with serious mental illness need intensive support. They need intensive support like to see if they comply with medications, psychosocial rehabilitation, managing money, finding places to live and maintaining their home. They need very intensive supports.